Hello, my name is Carolyn Johnson, and in the following video reflection, I will review my experience presenting a problem-focused discharge educational packet aimed at reducing rates of driveline exit site infections in the LVAD population and performing a targeted skills assessment to evaluate learning outcomes via the teach-back method, as well as the ways in which this experience has contributed to both my personal and professional development as a baccalaureate-prepared nurse. Driveline exit site infections in the LVAD population are a prevalent concern post-implementation of this mechanical circulatory support device and, as explained in a 2021 article published to the Journal of Cardiothoracic Surgery, lead to complicated courses of care in approximately 28% of LVAD patients. These infections, as noted in the Open Journal of Cardiac Surgery, can lead to increased morbidity and mortality in this patient population. For this reason, I decided to begin my Capstone experience by spending my practicum hours on the cardiac specialty medical surgical intensive care unit, of which I am currently a staff nurse, and meeting with LVAD patients with a history of driveline exit site infection to discuss concerns, evaluate health literacy, and pinpoint root causes for increased rates of infection in order to better guide the development of my intervention. I also spent a portion of these practicum hours meeting with industry experts, including wound care and infection control specialists, to gather opinions and further shape intervention components. The first 3 meetings which I conducted with members of this patient population and subject matter experts, occurring on November 24, 2021, December 28, 2021, and January 6, 2022, respectively, each lasted 2 hours and were carried out face-to-face in patient rooms as well as in the respective offices of the wound care and infectious disease teams. In these meetings, concerns and ideas regarding the prevalence of driveline exit site infections at this facility and their impact on quality of care, patient safety, accessibility of necessary treatments, budgetary impacts to the facility, care coordination practices, and the perceived helpfulness and extent to which technology and community resources are utilized in the management of these patients were discussed. Ultimately, the common thread connecting the major concerns for barriers to successful patient outcomes in these areas included limited health literacy, poor disease self-management, and frequent readmissions, all factors which were contributing to decreased quality of life and negative outcomes as reported in these patient interactions. Following thorough research of current, credible, evidence-based literature regarding best practices for management of infection, I found that failures in adequate patient education, as noted in a 2021 article published to the peer-reviewed journal BMJ Open Quality, were also a cause for these same barriers to successful patient outcomes, and therefore decided to focus my Capstone intervention on a goal of improving educational outcomes as a means by which to limit instances of driveline exit site infections. To do this, I began by creating an educational discharge packet which reviewed important information for the successful care of the driveline exit site in the home setting, specifically as it relates to infection prevention through meticulous sterile technique during the driveline dressing change procedure. To begin, I listed all supplies that would be needed for performance of the dressing change, including pictures of unfamiliar items for reference. I then proceeded to include step-by-step instructions for the entire dressing change procedure, which would help to guide the patient in utilizing the correct supplies at the correct times while maintaining an aseptic technique. Upon meeting with my patient for the final time on January 15, 2022, for 3 hours, I thoroughly explained all aspects of this process, allowing time for any questions and waiting for positive feedback from the patient that the education had been successful. The educational discharge packet was then provided to the patient as a hard copy to take home and reference during future dressing changes. For the final portion of this intervention, I provided the patient with the supplies necessary to perform the dressing change as we had just reviewed, and requested that they utilize the teach-back method to offer an objective demonstration that learning had occurred. I then utilized an accompanying skills assessment which I designed to evaluate for successful completion of competencies required for the sterile dressing change procedure. The patient was able to complete this entire educational session and skills assessment satisfactorily, and remarked that this tool was very helpful and would be a good source for reference in the home, as they have had problems with maintaining sterile technique during dressing changes in the past and have experienced recurrent driveline infections. The patient added that they plan to use this educational packet for guidance each time they change their driveline exit site dressing at home. This intervention has therefore enhanced the patient experience by offering a way to increase health literacy, empower self-care, reduce readmissions, and promote a higher quality of life. The principles of evidence-based practice thoroughly informed this intervention, and reference of many current peer-reviewed sources of credible information regarding the problem of driveline exit site infections in the LVAD population were consulted prior to its design and presentation. As explained by the CDC, successful evidence-based practice involves the synthesis of currently available research, available expertise of clinicians comprising the care team, and individual preferences of the patient or target population into a singular approach to address health concerns from a holistic perspective. In this case, I first met with patients individually to discuss goals and perceptions of their LVAD self-management capabilities and received feedback on concerns such as difficulty understanding instructions for self-care, high risk for infection, and a desire to reduce frequent hospitalizations. I also met with subject matter experts in the wound care and infectious disease departments who identified insufficient knowledge as it relates to care of the driveline exit site as a major contributing factor to this problem. I then chose to integrate these concerns with recommendations from multiple sources of current peer-reviewed literature on the benefits of patient education and knowledge assessment via the teach-back method, including the British Medical Journal, Federal Practitioner Journal, and the American College of Cardiology to guide the development of my Capstone intervention. Healthcare technology was successfully leveraged in this Capstone project through the reference of current literature and evidence-based recommendations on best practices for minimization of infection and care of the driveline exit site in the LVAD population. Ultimately, this intervention was mainly based in education on sterile technique and disease self-management, and therefore electronic technology was not heavily utilized. However, through reference of sources such as the Journal of Critical Care and the Journal of Hospital Infection, a standard procedure for driveline exit site dressing changes was developed, including recommended technologies for optimization of sterility, such as the use of chlorhexidine gluconate swab sticks during dressing changes for optimal minimization of driveline exit site infections. In future practice, extensive research in healthcare technology may lead to infection prevention opportunities such as the development of a fully implantable LVAD without the need for a driveline wire, for example, which would greatly reduce the risk for this type of infection and promote positive patient outcomes. However, until healthcare technology can be utilized in this way, current evidence-based infection prevention activities and technologies must instead be leveraged in the development of interventions for optimization of the patient's clinical outcomes, such as the educational discharge packet and knowledge assessment presented in this Capstone project. Health policy also influenced the planning and implementation of this Capstone project, as I thoroughly referenced New Jersey's State NURS Practice Act and the Healthy People 2030 government initiative prior to designing this educational discharge packet to ensure that all nursing actions and expected outcomes aligned with the outlined nursing scope of practice and supported the achievement of national health objectives. The New Jersey State Nurse Practice Act, for example, permits and expects nursing actions including patient assessment, generation of nursing diagnoses, and execution of intervention as it relates to these nursing diagnoses, and provision of care as prescribed by a healthcare provider. To reflect this, the Capstone intervention which I designed targeted a nursing diagnosis of insufficient knowledge and proposed and executed an intervention in the format of an educational discharge packet and skills assessment for evaluation of learning outcomes, as suggested to fall within the scope of practice of a baccalaureate-prepared nurse per the New Jersey Board of Nursing. The Healthy People 2030 government initiative was mainly applied in goal setting for this intervention, as it is a nationally recognized health objective to reduce hospital admissions in the heart failure population by 2030. With this in mind, I allowed the government policy to guide the conduction of my evidence-based research for methods to improve disease self-management in the home setting for this population. In incorporating these state and governmental health policies in this way, I have successfully integrated the role of the baccalaureate-prepared nurse in policy implementation. It is a professional responsibility, as outlined in American Nurse Journal, to contribute to policymaking and stratification efforts, as doing so reduces the risk for pessimism, resentment, and burnout among nurses, as well as promotes utilization of current evidence from a collaborative approach to optimize patient outcomes in general. The educational outcomes seen following presentation of this discharge packet and subsequent skills assessment met my expectations, as the participating patient demonstrated both subjective and objective proof of positive learning outcomes. Prior to presentation of this education, the patient expressed concerns regarding uncertainty in their ability to self-manage their driveline exit site and adequately prevent infection to avoid readmission. However, following the presentation of my Capstone project, the patient reported much higher feelings of confidence and was able to successfully demonstrate a sterile driveline exit site dressing change without site contamination. Following collaborative review of the educational content and patient outcomes with the wound care and infectious disease teams, I believe that this intervention can be reasonably and effectively implemented as a best practice during all discharges of LVAD patients at this facility. A hard copy educational packet is very cost-effective and has the potential to promote necessary self-management skills which will limit very costly readmissions. This intervention, however, is not necessarily generalizable outside of this particular setting due to the fact that it is targeted for a very specific population and contains information and goals to the heart failure specific to the heart failure population receiving mechanical circulatory support following LVAD implantation. Ultimately, the main priority in the development of this intervention was to promote positive patient outcomes as supported by ethical standards of care. To achieve this goal, I frequently reference the provisions of ethical care as outlined in the American Nurses Association Code of Ethics for Nurses to ensure that all intervention components were compliant with these standards. The provisions that were most influential in the design of this discharge educational packet and skills assessment for the reduction of driveline exit site infections in the LVAD population included those which discussed patient advocacy, utilization of the authority of nursing practice for ethical decision-making and care planning, delivery of compassionate care, participation in evidence-based practice, and reduction of health disparities. The creation and provision of thorough patient education upholds these ethical standards by empowering members of the LVAD population to self-manage their care supported by current evidence and an available care team that is acutely familiar with their clinical needs and goals. Throughout the development process, I have gained extensive and well-rounded population-specific knowledge as it relates to the care and management of LVAD patients, of which I have taken particular satisfaction due to its potential to enhance my ability to care for my patients from a more holistic perspective in my personal practice as a baccalaureate-prepared nurse. Through this research, I have realized the significance of continuity of care and extension of health promotion activities in continuing to care for patients outside of the inpatient setting and promoting improvements in quality of life from all perspectives. In this way, I will become a better patient advocate and more supportive member of the care team at my facility.